Thanks very much, Jean-Louis. Yes, so what I'm going to spend the next 20 minutes on is giving you some idea of one of the last ADQI meetings, ADQI 15, that was held in Banff, Canada, focused around acute kidney injury in the era of big data. So what is big data? We've heard this a lot in the popular media. We may even hear this in our hospital informatics context. Big data can really be characterized by the 4 V's, if you like. The sheer volume of data that we're generating today, the velocity of data, so how fast we are actually generating it and how fast we're analyzing it. The variety of data, so where we actually obtain data from, the variety of sources, and also the veracity of data. Because we have so many new sources of data that stream into our collective consciousness, if you like, in the ICU or hospitalized setting, there can be some uncertainty about this data. And we need to be able to understand that. So big data is now certainly raising eyebrows in the popular media. I don't know if any of you have ever read any of these books. The first book on the left, called Big Data, is a very interesting exploration of big data in big business and how it's transforming big business in the world. The middle one, Dataclysm, is an investigation of big data in social media and in dating websites and the like. So if you're looking for an entertaining read on a flight home, this one is actually quite alarming to know how much dating websites might know about you if you, in fact, are on one of them. And the last one is The Signal and the Noise by Nate Silver, who's the CEO of 538.com. Very, very illuminating book focused on big data and predictive analytics in settings like sports and gaming, and importantly, elections. And Nate Silver is very good at predicting the outcomes of elections in the United States. So I really like this cartoon because it gives you some sense about how fast, how much, the variety of data that in fact is being generated every minute of every day. And I'll just give you a second to look at one of those things, but it is just unbelievable how much data and how we are datafied in our world today. All of you looking at your phones right now or doing other things on your smartwatches and your smart pens and whatever else, they all leave a data exhaust trail, and it generates data. And it's clear that data is becoming more important and more prevalent in healthcare. We are now in a process of converting all of our data to electronic sources to some extent. By show of hands, who in here routinely works at the bedside or in your everyday practice with electronic health records and clinical information systems, by show of hands? So a good number of you, maybe half or so, yeah, and I think that's only going to increase as we go forward. This is a very elegant piece written in the Annals of American Thoracic Society by Jack Awashina about big data and the datification of healthcare. And really, his claim is that big data is seeking to bring new technologies of data acquisition, data integration, and data analysis into clinical research, hospital operations, and clinical practice. So what are some of the opportunities? The big promises of big data are, in fact, we're going to improve efficiency. We're going to reduce waste. We're going to improve the health services delivery, the quality of care that patients receive. And as a consequence, we're going to reduce costs. But there are challenges with big data that you have to recognize as well. Data is growing faster than our capacity probably to adequately analyze it. There's uncertainty around certain unconventional sources of data, and I'll show you an example of that. And then there's issues around data privacy and security and ownership, in particular with some of these big data warehouses that you're seeing develop around health. But there's no question that healthcare is investing in big data. And here's some, basically Oxford University has invested 30 million pounds in a big data center, full stop. And it's certainly in the popular media about how big data is going to save us from all our acute and chronic ailments, to say the least. So how is it being applied in health research, if you like, or in epidemiology? And this was a very interesting study published a few years ago that looked at Facebook likes amongst patients who lived in the New York City boroughs, and it correlated that with obesity rates. And really what they looked at was whether you liked watching TV and how fat you were. And it showed that it was actually very good at predicting obesity rates in various boroughs in New York City. But big data is not necessarily always accurate, and many of you may be aware of the sort of mishap with Google flu trends during the 2009, and then again in the 2010 through 12 influenza epidemics, whereby subtle changes in the Google search algorithms actually contributed to a 50% excess sort of reporting of flu cases compared with the gold standard, which was the CDC actually reporting actual cases. So we're not perfect. Big data is not perfect, and we have to be cognizant of that. But that being said, we asked the question whether there's a role for big data in acute kidney injury. And some of the rationale, and here's some of the rationale of why that came about. In 2002, as early as the second ADQI meeting that ever occurred, in fact, identification of innovative technology or information technology as a core concept was a need of attention for acute kidney injury and renal replacement therapy. I'd like to say further that AKI is a common syndrome, as we know. It has a consensus definition, perhaps, how we can anchor events in EHRs. In addition, it poses significant risk for poor outcome. It's expensive, and care is suboptimal. So all of these elements would suggest that AKI may be well-suited for big data. We searched for AKI and big data before our meeting, and we didn't find anything, in fact. So PubMed was completely devoid of the two terms AKI and big data, I guess, until our consensus meeting. So what we did with my co-chairs, Stuart Goldstein, John Kellum, and Claudia Ronco, is that we invited everyone to Banff, Canada for a 2-day consensus meeting in the typical ADQI format to discuss big data in the era of acute kidney injury, or acute kidney injury in the era of big data. And we had a large collection of nephrologists, intensivists, we had pharmacists, we had people representing biostatistics, epidemiology, health informatics, and we had various partners from industry as well to focus on this. And we focused on 5 basic themes. One was the idea of risk identification, forecasting, or predictive analytics leveraged through an EMR to predict AKI. The second was applications for detecting acute kidney injury, again, through your EHR. And then also alerting, so not only detection, but then alerting providers, if you like, about the development of acute kidney injury, and then the idea about integrated clinical decision support. Finally, we looked at AKI in administrative data sets, and we also tried to look at the communication of all these various sources of data and how we may be able to follow the arc of a patient's care through the health system if they develop an episode of acute kidney injury, in particular in instances where healthcare can be very siloed. So group 1, more specifically, looked at the development and utilization of risk identification, predictive analytics, and forecasting applications for AKI, and it was chaired by Scott Sutherland. And really what they were looking at, this is a figure that conceptually gives you the idea, is that electronic health medical records will give us a lot of information about patients that we can use to predict at the time of entry into hospital, in the emergency department, or wherever, whether they have some risk and whether that risk is going to be modified over time for developing acute kidney injury. Again, anchored on a consensus definition for acute kidney injury, which we can then search out through our laboratory systems. And they developed a process by which this might occur. They believe that, their statements believe that, they would use conventional methods like logistic regression, but then start to integrate big data analytic methods as well, like cluster analysis, that might help to identify patients in real time. And again, this is already being done to some extent. This is a study that looked at pooling 3 different data sources: administrative data, physician computerized entry, and laboratory data into a predictive analytic program that would predict whether a patient had risk of developing acute kidney injury or not. And as a consequence, you may be able to alter your processes of care to reduce that risk further. Work group 2 looked at focused on the principles for design and development of novel applications to detect and classify acute kidney injury, leveraged again through electronic health records. It was chaired by Matt James at the University of Calgary. And the consensus statements really were that this group believed that we should anchor these events on consensus definitions for acute kidney injury, that tools to detect acute kidney injury can be built relatively simply in computer information systems and electronic health records, such as using absolute values of creatinine, changes in creatinine, and when possible, changes in urine output. But importantly, they also concluded that rather than the alert, the detection being a label of acute kidney injury, they believe this should be an opportunity to prompt further evaluation and, if you like, adjudication of whether a patient truly had acute kidney injury. And this is based on the premise that the operative characteristics of a lot of these detection tools are not ideal. So here is sort of a conceptual idea of what they're talking about. You could use serum creatinine at the top of the pyramid. That's relatively simple to design and implement. However, you can enrich your data by other sources that might enhance your predictive ability to detect acute kidney injury. This may be less feasible, but this would generally lead to improved sensitivity and specificity for true events of acute kidney injury. The third group looked at interfacing the electronic health record for automated at-risk alerting, overt acute kidney injury alerting, or in fact QA alerting in renal replacement therapy. So this is the efferent limb, if you like. This would be, there's a detection of an event, and how does that detection get to the provider? And what kind of information is necessary to provide that provider to alter processes of care, change behavior, improve outcomes for patients? It was chaired by Eric Coste. And here you can see some overview of the complexity of the exposures that would go into this electronic alerting process, right? Technological factors, human factors, and delivery factors all seem to dictate what would happen to that alert once it traveled to the provider, and what the outcome would necessarily be to change behavior in providers to improve outcomes. And certainly we've seen this study by Perry Wilson. We saw it a little bit earlier today. But basically, electronic alerts in this study didn't translate into significant changes in processes of care, and certainly didn't translate into changes in outcomes for patients. And one of the mechanisms by why this study may have not shown any improvements in outcomes was how clinical decision support was integrated and delivered to the providers and how they reacted to it. I already showed you this slide in my first presentation. Again, I think this is an excellent example of where a quality assurance project built around electronic alerting that interacts with human factors can alter processes of care and clearly improve outcomes by avoiding unnecessary episodes of acute kidney injury. But one of the challenges that we do have for sure is that electronic health records, as smart as they are, can send us a lot of baggage. And how many people here get sent messages from their electronic health records by a show of hands? Right, this is a very elegant study that was published in the Annals, or in the Archives for JAMA Internal Medicine last week, and basically shows that some providers can receive up to 120 messages from their EHR a day. And that's very challenging for us as busy physicians and clinicians to understand that this volume, what's important and what's not important, what could be ignored and what can't be ignored. And this takes time for us to get through all these messages, and this may be one barrier to the adoption of these kinds of electronic alerts. Fourth, we looked at how AKI is coded in administrative and claims and registry databases, and tried to identify barriers to progress in AKI care as a consequence of coding. The consensus statements here were that commonly used administrative codes for AKI and administrative data lack sensitivity, though they have high specificity. Major limitations are that, in general, there's poor awareness about acute kidney injury. If it's not coded properly, coders, who work in the basements of our hospitals and enter these administrative data will not find it. And there's certainly a lack of granular information provided about severity, about etiology, etc. in administrative data. All we really get is a code of yes or no. We believe that the ideal definition in administrative databases would enable cross-registry communication. And again, it gets at this idea that if you had an episode of AKI in one hospital, that could communicate with another hospital's clinical information system such that their risk may be modified there for developing subsequent AKI. In addition, we wanted to know how we could leverage administrative data for the purpose of clinical trials. And certainly big data and administrative data are starting to play a role, and we're starting to show new methodologies to be able to conduct health services research and clinical trials that may enable improvements in patient care. And one example is this trial called the TASTE trial that was published in the New England Journal not long ago. This was leveraged completely off the Sweetheart database in Sweden, which is a comprehensive registry of patients who have a cardiac cath and present with cardiac symptoms, so they're investigated. Basically, this was a randomized trial that looked at patients who had, they're randomized to either having a PCI or a PCI plus aspiration of thrombus. And basically what they did was they didn't have to collect any data on these patients whatsoever. The registry did it all. All they did was set up the randomization process. And they randomized something like 6,000 patients in approximately 3 years at a cost of about $50 per patient enrolled. That's prohibitively inexpensive. That's amazing, right? So if we can leverage some of our big data sources to conduct clinical trials of this nature, not only can we complete them more quickly, but we can be more assured that the data is going to be as comprehensive and high quality as we need, and we can do it much less expensively. Finally, work group 5, chaired by Ravi Mehta, looked at the continuum of AKI, tracing AKI across all the data sources that you may interact with in health services. I showed you this piece earlier. We're utilizing more renal replacement therapy. And one of the challenges that we have because we're doing that is that we probably think we're going to be following patients as outpatients more often. They have a severe episode of acute kidney injury in hospital. They're treated with renal replacement therapy. They recover in the ICU. They go to the ward. They leave hospital. Yet they're never seen by a nephrologist. And this work from Vanderbilt University, led by Eddie Sue, basically suggests that only about 8% of patients are followed up by nephrologists and receive nephrology-specific care after having had an episode of severe acute kidney injury. And work from my colleague Ron Wald in Toronto, Ontario, suggests that if you are in fact followed up by a nephrologist, whatever the mechanism may be, you might have an improved survival over time and less risk of development of more severe CKD. And that's what his data here shows as well. So clearly, this is one of the priorities that Group 5 was trying to address, was this comprehensive idea that you could trace a patient's episode of AKI with them through all the EMRs that they interact with over time. And here's a conceptual model of all the opportunities by where you may collect data and understand how these patients do over time. So with that, big data and AKI, I think there's opportunities to leverage our electronic health information and clinical information systems and our administrative and registry databases to assess for risk, detect and monitor AKI, and introduce platforms of evidence-informed clinical decision support that ultimately will impact processes of care to the betterment of patient care. Ideally, big data and AKI is going to contribute to greater consistency of care, right? Avoid harm, improve patient outcomes, and maybe translate into more efficient use of health resources. There are challenges, as I mentioned before. The data is growing quickly. We're not sure how to analyze it, the layperson. These are big data analytic techniques that are not sort of something you run off your laptop routinely. And there's issues around data privacy, data sharing, and security, of course. I would encourage you to look at the series of publications that came out from this ADQI meeting. They were all published a couple of months ago in the Canadian Journal of Kidney Health and Disease. They're all open access. There's a series of 5 articles and an editorial. So please visit those if you're interested in reading a little bit more details about those. Again, our ADQI meeting in Banff wouldn't have been possible without the generous support of a variety of industry and academic sponsors, so we thank them as well. And thank you.